Well, good evening. Welcome to the 7th summer of this Healthy Living Lecture Series brought to you by UAF's Summer Sessions in Lifelong Learning. I'm Mike Powers. I'll be introducing tonight's speaker. As a reminder, these Healthy Living Lecture Series are the result of Michelle Bartlett's vision and hard work. She's the director of UAF's Summer Sessions Lifelong Learning. Great connector over the years. An advocate for demonstrating the value of what the university brings to the quality of life and the depth of lectures and courses and travel programs and school programs offered through her department. With that, let me introduce tonight's speaker, Dr. Clay Van Leeuwen, board-certified oral maxillofacial surgeon practicing in Fairbanks since 2016. Broad scope of practice including facial trauma and reconstruction, corrective jaw surgery, facial cosmetics, oral and dental surgery. Dr. Van Leeuwen attended the dental school at Case Western Reserve University in Cleveland, Ohio, graduated in 2010, followed by medical school and residency at the University of Nebraska Medical Center in Omaha. He's married with 4 boys, actively involved in the hockey community of Fairbanks. One of Dr. Van Leeuwen's specialized clinical practices, and of particular interest tonight, is dental implants for the replacement of missing or failing teeth. Tonight's talk with Dr. Van Leeuwen is entitled, What to Know About Dental Implants, How and Why and When. And with that, let me turn this over to Dr. Clay Van Leeuwen.
Well, thank everybody for coming and everybody online that's attending. I thought I was going to have to bring some of my staff and have them sit out there and give me an audience to talk to. So I'm glad to see people braved it and came out. I'm not used to having somebody introduce me, so I had an introduction slide. But I went to dental school in Cleveland, Ohio. We got the Rock and Roll Hall of Fame there. That's one of Cleveland's claim to fame, the Rock and Roll Hall of Fame. Also known as the Mistake on the Lake. I don't think Cleveland likes to be referred to that, but that's a name that they go by. When I first moved to Cleveland, I met a guy, and he's a local, really proud. Clevelanders are really proud of Cleveland, but he said, Cleveland gets a bad rap, but we have a saying here in Cleveland. I said, oh, what's the saying? And he said, well, at least we're not Detroit. And I thought, oh, geez, okay. So anyway, that's Cleveland. After Cleveland, we moved to Omaha, Nebraska. Omaha was great. While I was in Omaha, I attended medical school and then residency. I had the unique opportunity in Omaha to fly on one of Warren Buffett's private jets. So the Berkshire Hathaway Group, they're very generously, they donate their fleet of jets to the transplant service. So anytime they need to go pick up an organ, they take these jets. So one night we got the call, we had to go pick up a kidney in Pennsylvania. We jumped on this jet, flew to Pennsylvania, picked up the kidney, picked up a Philly steak and cheese, flew back to Omaha. It was all about like 6 hours. I was like, oh man, this is the way to go here with travel. But nowadays, I do more flying in a bush plane. I'm not a pilot, but I'm fortunate enough to have a few friends that fly. And so that's the way to go. I think having friends that fly is better than flying yourself. So I talked about this a little bit, but an oral maxillofacial surgeon, other than just a mouthful to say, pretty broad scope. I did training in all these areas. Here in town, I take the facial trauma call at Fairbanks Memorial Hospital about 2 weeks out of the month. We do dental alveolar surgery, facial cosmetic surgery, TMJ, dental implants, sleep apnea. So it's kind of a broad scope, but tonight we're going to be talking mostly about dental implants. When I'm not at work, you'll find me in the stands. I have 4 boys that are all playing hockey, so that ends up being a second full-time job. This was my first hockey puck to the face. Not mine personally, but someone who came to see me. So public service announcement, full face mask, not just the visor. So dental implants. As we start to talk about dental implants, I want to get a little nomenclature out there just so we're referring to the same thing. A lot of times when patients come to see me, they say I need a dental implant, and I'm talking about one thing, they're kind of talking about another thing. So first we'll start with regular tooth anatomy. You have the portion of the tooth that's visible in the mouth, that's called the crown. Then it's got kind of this intermediate structure, the neck, and then the root structure. So a tooth's a lot like iceberg, where the majority of it's, you don't see it necessarily. It's submerged underneath the gum tissue and the bone. And then similarly, dental implant has multiple components. So technically, the screw portion of is the dental implant. That's the part that's actually implanted or inserted into the bone. So usually when I talk about an implant, I'm talking about the screw itself. Most of the time when a patient's talking about an implant, they're kind of talking about just replacing the tooth, the missing tooth. But it's got these three components to it. So the implant or the screw, what we call an abutment, which will sort of serve as that neck that comes up through the gum tissue, and then a crown that goes over the top of the abutment. And those crowns can be glued on, cemented on, they can be held in with the screw. A bunch of different ways to do that, a bunch of different reasons why you would do that. But that's sort of the three main components there. So I like history, so talk a little bit about the history of dental implants. A lot of times in medicine we get something called serendipitous discovery, where we come across something and we weren't even really looking for it. Probably the most famous example is this Alexander Fleming. He was a scientist, Irish, I think, maybe Scottish. Anyway, he was working with bacteria, Staphylococcus bacteria, and he one time dripped a tear onto one of the augers that he was culturing bacteria on, and he noticed that after a little bit there was an area where there was no bacterial growth around his tear. So he kind of looked into the reason for that, and he discovered that the tear had an enzyme in it called lysozyme, which appeared to have some antibacterial properties. So he kind of filed that away in his head, and about 5 years later, he was cleaning up some of his lab, and he had some old petri dishes, and I guess was fairly common at the time that the petri dish was collecting some mold on it, and so most of the time these things were just discarded. But he looked at that mold, and he remembered his tear and he saw that there was no bacteria growing around the mold either. And so that led him to question what was going on here. Maybe this mold had some antibacterial properties. Well, the mold was from the family Penicillium, and he discovered penicillin this way. And it wasn't what he was working on, but that was how it was discovered. And probably that's the dawn of modern medicine, antibiotics. I mean, that was and totally serendipitously discovered. Another example, Viagra. Viagra was a anti-blood pressure medication. Was not very effective for lowering blood pressure, but an observant nurse noticed during the trial that it had another useful effect. So it launched a whole line of products there. So much like these examples, dental implants were discovered the same way. This is Per Ingvar Brännmark. He was a Swedish orthopedic surgeon, actually, and a researcher, and he's called the father of dental implants. And he was not trying to develop dental implants. He was actually working on studying blood vessels, microvascular blood supply to a bone. In order to do that, he developed a little optical device that he was inserting into the femur of rabbits. And then this would allow him to take some measurements and do the research on the blood supply. Well, when they went to remove these, intricate contraptions, and so they could reuse them, they found that while they were screwed in initially, they were having a very difficult time getting them to come out. And in fact, there was actually a connection of the bone to this titanium machine or device, and this was not the purpose of his study. He called it pretty annoying because he was trying to get these things back and he was having a hard time getting them out. But eventually he realized that, hey, even though he's an orthopedic surgeon, he started thinking, what are some practical applications? This was really kind of the first example of what we call a biocompatible material. Most of the time when we get metals or whatever, the body sort of rejects those things. They treat them as a foreign body. And in this situation, that we actually had this interface, and he termed that osseointegration, osseo-bone integration. And eventually, although he's an orthopedic surgeon, he realized that this could, be transformative for restoring missing teeth. And his first patient was a Swedish guy named Gösta Larsson, and he was born with some facial deformities and had lost his teeth early on. And so he was, a willing candidate, and Dr. Brennemark put these implants in 1965. That patient passed away in 2006, and those implants were all still in place. So pretty remarkable. So talk a little bit about the consequences of missing teeth, and that give us a little bit of a jump off as to why we would want to replace those. So one of the main, there's two types of bone in the jaws. You have your kind of basilar bone, which is sort of the foundation, and then you have something called alveolar bone. And alveolar bone is just bone that's there specifically to hold teeth in place. And so once teeth are lost, that alveolar bone kind of says, I don't have a purpose in life, and they could use this calcium somewhere else. And so it starts to resorb away. So you can see on this x-ray here, this is the normal bone level kind of here, and then this area where they're missing the teeth, the bone dips way down here. Example here of a skull, human skull that expired with teeth in place, and you can see the thickness of the jaw here versus somebody who died without teeth, and how thin that area has become. Back here, kind of the same again, but the alveolar bone segment is all resorbed away. So teeth preserve the bone. The bone aids in aesthetics, and so this is sort of what you see with as you lose teeth, that bone continues to resorb away over time. You get loss of volume, which leads to excessive skin sag and wrinkling. You can close now because the teeth aren't preventing you from closing, so you overclose, and that shortens that lower third of your face, and it just changes your facial aesthetics. And so also, teeth want to be in contact with other teeth, and so when you lose a tooth, the teeth around it begin to shift and change. And so teeth behind it will sort of drift forward, and teeth above have a tendency to come down. These front teeth, not typically, but can potentially tilt backwards. And the shifting of the teeth can cause problems with hygiene. It can cause problems that change the way you bite. And then if you decide to, this isn't a week's or a month's process. This is more like a year's process where we see this shifting and tilting. But now if you want to fix this, it's challenging, and you need to maybe add in some orthodontics to kind of upright and straighten the teeth in order to make that area adequate for a dental implant. Obviously, if you don't have teeth, chewing becomes a challenge. But chewing is more than just, or it's more complicated or complex than it sounds. Chewing is the initiation of the digestive process. So once you start chewing, you start to secrete saliva. The saliva is important for breaking food down. It's important for bathing the teeth with minerals. That chewing process signals your stomach to begin to secrete acids that further break the food down, your pancreas. And it's kind of the initiation of the whole GI tract there. And so with chewing, if we lose that ability to chew, we end up changing our diet. And so we're going to eat things that are, require less chewing. Most of the time, those are heavily processed foods, caloric dense foods, and unhealthy foods. And an interesting study showed that on average, people were eating meals as fast as 7 minutes. So if you think about how fast we're eating food, and chewing's a big part of that. If you're eating raw fruits and vegetables and things that require a lot of chewing, that obviously slows that process down. It takes 20 minutes for your stomach to signal your brain that you're full. So, you can see how just eating with that kind of rapidity will lead to overeating. And again, when you're overeating with densely caloric food, then it becomes a problem. So I thought this was interesting. There's a biologist named Stephen Rinelli. He's a hunter biologist guy, and he had a book on the American buffalo. And he talked about how a buffalo in the wild will live 12 to 15 years on average. And one of the main reasons that they die, obviously there's predation and weather and all these things, but one of the big problems for wild buffalo is they eat off the ground, and the ground is covered in dirt. And so as they're taking that food up, their food source is just riddled with dirt, and that causes attrition or wear on their teeth. So a lot of animals that graze, such as the buffalo, will end up dying because they lose their teeth. And a buffalo in the captivity can live over 25 years, and a big part of that again is the teeth. So obviously we don't die as quickly. We have our brains have allowed us to develop these other foods and things but it does change our diet. It does change our overall health when we don't have teeth to maintain a proper diet. Speech, speech is affected whether you lose one teeth or multiple teeth. When you get replacement teeth, all that stuff is new, and your tongue has to figure out where everything is, and it can change the way you speak. This is a photo taken from my iPhone, actually. I was pretty impressed by the capability there. But this was up in the Brooks Range. We were backpacking last summer, and it was just kind of the perfect spot. So, let's see. Replacing teeth. What are our options to replace teeth? Eventually we'll talk about dental implants, but if we're not going to do a dental implant, what are our options? And these are probably the three main options. So a bridge is, you can have, this would be an example of a 3-unit bridge. You're missing one tooth. If you're missing multiple teeth, then you can have a larger bridge. But you end up taking the adjacent teeth and preparing those teeth. Preparing is a nice way to describe it. You're shaving those teeth down so that you can put a crown over the top of those teeth. And then they'll fuse the crown to what we call a pontic, where you're missing a tooth. And so these are your abutments, and this is your pontic. And now we have these 2 teeth and roots supporting this area of 3 teeth. Before dental implants, bridges were sort of the gold standard. They have a lot of advantages, but obviously they have some disadvantages as well. One of those things is if these adjacent teeth are perfectly healthy, and you go in and have to cut those teeth down in order to facilitate putting a bridge on there, and that obviously has some disadvantage. The second we cut on teeth, they become inherently weaker. So even though sometimes we're cutting into a tooth to remove decay or fixing it, it's still inherently weakening the tooth. Also, these things are fused together here, so flossing becomes a challenge. You have to get special cleaning instruments to kind of clean underneath the bridge. So again, they have their advantages, and they're still widely used, but they have their drawbacks as well. Partial dentures, if you're missing a single tooth or multiple teeth in different areas of the mouth, you can have a partial denture fabricated. A partial denture has clasps that kind of grab onto the adjacent teeth to help hold it in place, and then the missing teeth are then made part of the prosthesis. Again, good. These prevent a lot of the problems. If you're wearing that denture, it'll prevent some of the shifting of the teeth. It gives you more surface area to chew with. It returns some function, but it has drawbacks as well. Some of those things are the more teeth you replace with the partial denture, the more work you're asking the remaining teeth to do. So you have these partial dentures that are hooked or clasped to the remaining native teeth, and I had a professor in dental school that called partial dentures long-term tooth extractors, because over time they just sort of put extra stress and pressure on the adjacent or neighboring teeth, and over time you have a tendency to see where partial dentures sort of work themselves along the path to becoming a complete denture. A complete denture, again, it's better than nothing. It gives you something to chew with. They are functional, but a lot of people have a lot of issues with complete dentures. Part of the issue is fit and keeping them to stay in, especially on the lower jaw. It can be a challenge to keep the denture in. Even a well-functioning denture can have as low as 5 to 10% of the function of natural teeth when they look at chewing forces and efficacy of chewing. So they're good, but they're nowhere near what your native or your natural teeth can do. They can cause speech issues. They can cause change in taste, because the denture has what's called a flange, which is all this area that has to kind of go out and sit on the tissue that covers up all these minor salivary glands in your mouth and changes the way you taste food. And then even though these dentures sit on the bone, they don't stimulate the bone enough to prevent that bone from resorbing. So the bone, you still get, over time, you see that progressive bone loss. And then, in fact, dentures can sometimes make that worse. So then dental implants have some advantages over some of these other modalities. They prevent the bone loss. When an astronaut goes in outer space, they come back with osteoporosis because there's zero gravity up there and it's not stressing the bone, and bone responds to stress. So now when we insert a dental implant into the bone, it's stressing that bone, and that's causing that bone to turn over and maintain itself, as opposed to over time resorbing away. When you put a dental implant in, it doesn't affect the adjacent teeth. So if you have perfectly healthy teeth on the other side, a dental implant doesn't have to disturb or cause those teeth to be cut on. If you have a bridge, if you have an issue with one part of the bridge, you lose the whole bridge. With dental implants, if the adjacent teeth or the dental implant itself has an issue, you can sort of treat that individually. And then if it's a single tooth implant, it can, you don't have to clean underneath that, and it can make hygiene more normal or regular, like where you're able to floss in between the teeth. So just talk a little bit about the different types of dental implants. A lot of different things that we can do. If you lose a tooth, you can get a single tooth replacement with a dental implant. So this is kind of a nice little slide, kind of shows you the analogous parts of the dental implant. You have the implant itself, which I call like the artificial root, and then you have that abutment coming up through the gum tissue, and then a crown that's made to fit on the top of that. So if you lose a tooth, you can put a single implant in there, have a crown put on top of that implant, and you replace a single tooth with one implant. Depending on where that is, these abutments, they can, in the front area here, that can kind of show through. So they do a lot of fancy lab techniques, but they're trying to make this here so that's as aesthetic as possible. And you can see that you get a pretty good result with the dental implants. I mean, they can when done properly, hard to tell which one's an implant without an X-ray. So if you're missing multiple teeth, You can do a bridge, again, similar concept where you're missing 3 or 4 teeth. You don't necessarily have to put an implant in for every single tooth. Obviously, an implant costs money, and so if we can get 3 or 4 teeth out of 2 implants, that can be have some financial reward to it. If you do a bridge like this, obviously you run into some of the things similar to a bridge supported by teeth, where you're going to have to clean a little bit differently underneath this because you can't floss in between those teeth. But that's a way to placing 2 or 3 implants to restore multiple missing teeth is an option. If you're missing all your teeth, you can do different things to kind of help with the denture. This is called an implant overdenture, where you basically have a denture, like I talked about on the bottom. That denture wants to move around a lot because the floor of the mouth is moving. The tongue is always causing trouble. And that denture has a tendency to want to pop out. So by placing a couple of implants with this sort of a ball and hitch type of attachment, that can help hold that denture down. Now that denture is still primarily supported by resting on the tissue. It's just retained by the implants holding it in. But you can get significant improvement in retention of a denture with some implants. And then there's other options where if you place enough implants, and probably 4 is the minimum, you can then create a bridge or I call it a bridge. There's a lot of different names for it, but essentially this is not resting on the tissue at all. It's just completely supported and retained by the dental implants. And when we do that, we start to get creative with the way we place the implants. We can tilt implants here. This one's at an angle, and we can do some things that we can't do with single implants because they're all splinted together and they support each other. But this is sort of if you're missing all your teeth, or the teeth that you have are in a condition such that fixing them doesn't really make a lot of sense, this is kind of a good option. I call it the Cadillac, if you will, of replacing a full arch of missing teeth. So quickly talk a little bit about the biomechanics of dental implants. Since Dr. Brandemark first discovered those implants, he had a totally machined, smooth surface titanium device. And they've gone, we talk about macro design, just what's the shape of the implant. We've got wide, fat, short implants. We've got long, we've got tapered, we've got parallel. They have connections that are external, or there's connections that go down into the implant. So there's all different types of implants, a bunch of different implant manufacturers. And, all these things are designed to kind of take care of a problem. And then sometimes when they come up with a new design, they create a new problem. So we're still in the process of developing the perfect dental implant. But nowadays the dental implants are pretty good. One of the biggest changes is what we call the micro surfaces of the implant. So this is like looking at the implant under a microscope. They've either acid etch or sandblast, or they put a coating on there that has these micro porosities, and that allows just a lot more surface area on that implant for the bone to heal to. And since they've done some of these things with the surface of the implants, they've really changed how long an implant takes to kind of come to restorability, the time when you're actually able to put a tooth on it. So this again is that process: osseointegration, bone integration. In the first 24 hours, that thing is held in there like a screw is when you screw a screw in a piece of wood. We call that primary or mechanical stability. And depending on when we put an implant in, depending on how tight that is, you'll either cover the implant up and bury it, and so it can heal, or sometimes you can put an abutment that comes up through the tissue. And we base that primarily on that primary stability. Then that bone is obviously injured when you drill into it to put the implant in. And so you start to get a wound healing process, new vessel formation, blood vessels. The osteoid or the bone cells begin to migrate to that implant surface. But around week 4, you have some resorption of the bone that was damaged by the implant placement, and you haven't had time enough for that implant to start to fuse to the bone. So you actually get a temporary loosening or a weakening, and that occurs around week 3 to 4. And then after that, pretty quickly you start to get what we call secondary stability, where that implant then begins to fuse to the bone. So the process, I'll try to make it simple, but it's not always simple. So, but essentially you come in with a bad tooth, that tooth needs to be removed. Depending on how the bone is in that area, you can either put the implant in at the same time, or sometimes the bone is inadequate and we need to improve the bone before we put the implant in. And so that can require a bone graft. And so this would be an example. This tooth is broken. If you were to pull the gum tissue back, you would actually see that instead of the bone being right here, there's bone loss because of that crack or infection or has caused resorption. So now if you were to put an implant in there, you would have a bunch of threads that are exposed. And that can, we'll talk about it a little bit later, but that can lead or potentially be the source of problems with that implant in the future. So a lot of times in this situation, we'll take and fill that socket, extraction socket in with a bone graft material, and you place a little membrane over the top of it, like a collagen type of a membrane, a little lid essentially to hold that bone graft in place. And then you allow that to heal for about 3 or 4 months. And after 3 or 4 months, you can then come back in and then put an implant into that, because now if an implant's put into good bone volume, they do pretty well. But if we try to cheat and we don't have adequate width or height, then that can lead to resorption of the bone after you put the implant in, and that can lead to problems down the road. So I like to try to prepare the site as well as possible in order to allow that implant the best chance to be successful over the long term. Sometimes we have individuals come to us who've been missing a tooth for a long time, and so we take an x-ray to see kind of what it looks like, and we find something like this, kind of a knife edge type of bone. So here you don't have adequate volume in a horizontal direction to put an implant in. If you're to put an implant in here, the back part of those threads would be exposed. So you can go in there and do a bone graft and try to rebuild that area. These are a little bit more complicated just because when you take a tooth out, there's kind of a socket or a hole that you can, it's like a cup. You just fill the cup up and put a lid on it. In this scenario here, you have to recreate some sort of 3-dimensional structure to hold that bone graft in place. So just because you've been missing a tooth for a while and you have some bone loss doesn't mean that you can't have an implant placed, but it may require some more complicated or complex bone grafting. But you can see here, this is the volume of that ridge. Dishes in there and dishes in there, and after the bone graft, now you have a lot of bone volume. So again, timeline, that can be anywhere from 3 to 12 months before you actually get the tooth on there. If you have the tooth taken out, or you come in and the area is perfect, it's already missing a tooth and the bone's great, you put an implant in as little as 3 months is conservative. Some people are doing it at 6 or 8 weeks, but 3 months is probably the average. But if you have to have a tooth removed and the bone's not in good situation, or you've been missing tooth for a long time and you have to have a bone graft, and some of those more complicated bone grafts will have to heal for about 6 months, and then you put the implant in, and then it's still another 3 or 4 months for the implant to heal. So that can take anywhere from 3 to 12 months to replace the tooth. So why do I hear so much about teeth in a day on the computer? Or not the computer, but the TV. There's all these advertisements for teeth in a day. Is that possible? Well, yes and no. It just kind of depends on what you're talking about. At the end of the day, an implant isn't in until it's osseo-integrated and fused. We wouldn't call an implant successful until it's fused to the bone and osseo-integrated. And so at a minimum, that's 6 to 12 weeks. But it is possible to put an implant in and put what we call like a provisional or a temporary crown on there. This is something we'll do in the front a lot because people, there's different options to kind of mask that. It's been nice with COVID because everybody just wears a mask. They don't care about missing a front tooth as much anymore. But that's a unique problem that we've had, or a unique solution that we've had over the last year. But prior to that, most people want to replace a tooth that's missing up front. So you can make a retainer or something that has a tooth on it. There's different things. But one thing that you can do is put a provisional on the implant immediately. So if the implant goes in and it has good primary stability, it torques we use a little torque wrench measured in Newton centimeters. So it's not pound-feet of torque by any means. But if it torques well, then you could put a temporary crown on there. We design these temporary crowns to be non-functional, meaning you are not supposed to eat or chew with that thing at all. One of the ways an implant can fail is if it's moving while that bone is trying to fuse to it. Instead of getting a bone to titanium interface, you get a little scar tissue there. And once you develop that scar tissue around the implant, bone's never going to fuse to that. And so if you got that implant moving because that tooth is getting used, then that can be a big problem. So we do put these in. Provisionals have a lot of use. They're really good for kind of shaping the gum tissue around a tooth. So a lot of times we like to put a provisional on in the front because it helps to really mold that gum tissue and help it have a real natural appearance. But it depends again on whether or not that implant's stable enough, whether or not you had to do a lot of grafting around it, type of a thing. And then if you're missing all of your teeth, or your teeth are in condition such that the remainder of them need to be removed, we talked a little bit about before that where we're putting at least 4 implants in, 4, 5, 6, 7, whatever. When we do something like that, you actually could, through the bridge that you hook to those implants, you splint all the implants together. And by splinting all those implants together, they begin to support each other. And that's why we can have an implant that's angled way off like this, and we correct with an angulated abutment. But normally, if we were to put an implant in like this and a single tooth implant, all those forces are going to be directed this way, and that's going to torque that implant, put a big cantilever on that implant. But by splitting it all together, you really, it distributes the load over the entire bridge. So you can have implants at funny angles and things like that. And in a scenario like this, we don't have them go eat steak that night, but you can get 4, 5, 6 implants, put a temporary bridge on it, and then be chewing with that bridge that night. That's still a provisional bridge. We usually wait to make the final bridge the 4 or 6 months to make sure that the implants have completely healed and osseo-integrated, and then they'll replace that provisional or temporary bridge with a more permanent bridge. But when you see the commercials on TV, this is usually the process they're talking about. So I have a lot of patients say, why does it take 12 months? The TV said I could have it in the same day, So it just sort of depends. They're not telling you everything, but it is possible, and there are some scenarios where it makes sense and it works well. So do implants implant longevity, do they last forever? Why do they fail? What are some reasonable expectations? So do they last forever? Emphatically, I would say no, but then maybe yes. So I always tell people that nothing that we do is as good as what God or nature gave you. So, and what God or nature gave you can fail. And so it's probably unreasonable to expect things to last forever. That being said, oftentimes an implant will last for a very, very long time, and even for a lifetime. So it's, I will say, as far as treatments go in dentistry, implants have some of the highest longevity of any of the treatments that we do. So they, on average, will last longer than a bridge. They, on average, will last more than partial dentures as those partial dentures begin to lose other teeth and things like that. This was an interesting study. They were trying to quantify how long does a dental implant last, and what they took a bunch of studies and kind of compared them all, and what they came up with here is that although slightly lower, dental implants fail at rates similar to natural healthy teeth. So obviously you can die with all your teeth that you were born with, or you can lose teeth along the way. Same thing with implants. You can have an implant put in that can last a lifetime, but implants can fail and do fail. And I think with the amount of implants that are being put in nowadays, we're seeing more failures, which is just makes sense. It's just a numbers game. But treating failing implants is sort of becoming another part of dentistry. So why do they fail? They can fail for a couple reasons. One of them, what we call early failure, is that implant, for whatever reason, didn't fuse to the bone. So we find out pretty early on, within the first couple weeks, these implants will fail, or at that 3 or 4 month mark, we'll go to check to torque that implant to see if it is fused, and we find that it hasn't fused. That's pretty rare, but it's possible. We call that an early failure, or a failure of that osseointegration piece. And then you have late failures, and usually the reason implants, they don't get cavities, so you're not gonna get decay or cavities around an implant, but they're held in by the bone. So if we have anything going on that disturbs the bone and causes bone loss, then you can get bone loss around an implant. So some of those things are, like I talked about, forces on that implant. You want that implant to be well supported. You don't want the implant sitting over here in a big long cantilever where it's like a diving board effect. The further you get out there, the more force is on that. So you want an implant that's well balanced, that's well positioned. You want the forces of chewing to kind of go straight down the axis of that implant. If it's not favorable, it can cause tilting or rocking, micro movements, but that stresses the bone and you begin to get bone loss. If you can't keep the implant clean, you can get peri-implantitis, just like you can get periodontal disease. So it's just inflammation of the tissues, the gum tissue and the bone around the implant. And it's sort of a challenging problem, because once you start to get a little bit of bone loss, now all teeth and even implants have a little pocket around them, and that pocket's usually 2 to 3 millimeters deep. But once you start to get inflammation, that pocket deepens. Well, as that pocket deepens, it makes it more difficult to clean that out. So now you get this kind of problem that's compounding upon itself. You're getting further and further bone loss. That pocket's getting deeper and deeper. Maintaining or cleaning that gets harder and harder. And so that's another way that implants can fail. Sometimes the crown portion of the tooth. So people come in and they'll say, "My implant's loose." I work with general dentists to put the whole thing together. I do the surgical part, and then they'll go see the dentist for the crown or the tooth. They come in, they'll say, "My implant's loose," and I'm hoping it's the crown, not the implant. That's an easier problem to fix. Crowns can be replaced on top of an implant. But sometimes just the cement that holds the crown on or the screw can get loose. The crown that's in the mouth can chip or break. Crowns can need to be replaced. But most of the time we can salvage, as long as the implant's in good condition, we can salvage the implant and just replace the crown. Health of the individual plays a big role. Smoking decreases our success rate. So if we look at implants overall, most studies will show 92-95% of implants that are placed are still in at 10 years. If we look at smokers and poorly controlled diabetics, now we're seeing like 86, 80, 88 range for dental implants. So, still successful and still possible, but in some of these systemic conditions can kind of decrease our success rates. And so it's just something you have to, ideally, we can get people to stop smoking. And I've actually had a lot of patients who have lost all their teeth or have severe periodontal disease, and they come and they're looking for that full arch replacement. and they're going to invest a significant amount of money to get that. And so they've used that as their motivation to stop smoking. I've probably had 8 or 9 patients at least that have solely because of this getting ready for the implants that they've stopped smoking. Probably more than that actually. It's doable. It's possible even if you're a smoker or if you're diabetic or any of those issues, but it does change our outcomes a little bit. Questions? It's kind of a lot to go over, but.
So for young hockey players that lose a tooth, and a lot of times they're advised not to replace a tooth until they get to college hockey, which is less risky than juniors. Do you get the movement that at that age group that you're going to have to fix later if you just leave it like cold?
Good question. So for kids, so implants are interesting because when an implant goes in, it will never move. Teeth move. Teeth are connected to the bone via ligament. And so that's why we can move teeth with braces or orthodontics. Implants, the implant goes in and it does not move. So if we put an implant into a child, what we'll end up seeing is the jaws have a tendency to expand and grow over time. So if you put an implant in, it might be perfectly aligned in like a 15 to 16-year-old, and then a couple of years later, that kid comes back. Now all these other teeth are down here and the implant's up here because that implant will not move. It's fused to the bone. And so the main reason we don't put implants in kids is because we wait till skeletal maturity. And when is that? That's kind of a hard question to answer. Younger for women than men, probably by 2 to 3 years. So, we're kind of finding now a little bit more and more that we're like, for women, we want to wait until they're late teens, 18, 19, 20, and then for young men, maybe 20 to 22, 23, something like that.
Yeah, maybe I missed part of it there when you mentioned why do dental implants fail. They don't get cavities. Was that?
Yeah. No, they don't. They don't get cavities. So that's cavities or caries or whatever you want to call it is the leading cause of tooth loss. But the way a cavity works is you eat food, bacteria in your mouth converts that sugar into an acid. Your tooth is a mineral, and it demineralizes that, the acid demineralizes the tooth, and then that allows that decay to kind of get into the tooth and begin to eat that tooth away. So dental implants, they don't have their porcelain or their zirconia, or they're different materials, but they don't get cavities. So that's how they're drastically different than regular teeth. Doesn't mean you don't have to clean them, but you have to clean them for a different reason. You have to clean them to keep the tissue around the implant healthy and not necessarily the implant itself healthy.
I'm interested in the subject of bone grafting. What is the material?
Good. Yeah, good question. So there are a lot of different materials that you can use. Originally, we used autogenous bone, meaning from the individual. That's still what we would call the gold standard. Your bone, when we take it out, it's alive, it's vital. It has a lot of cell signaling properties that actually tell your body to make more bone. So autogenous bone is what we like to use, but most of our patients don't like us to use autogenous bone because that, means maybe a second surgical site. We take bone from the leg, we can take bone from the hip, we can take bone from the skull, a lot of different areas, and depending on how much bone we need, depends on kind of the source. A lot of times we can take bone from other areas of the jaw. The majority of the bone grafting that I do is with cadaver bone. So this is a bone that's been processed, demineralized, and sterilized and packaged. And so the risk of, a lot of people ask about transmission of disease, and because of the way it's all processed and things like that, there's virtually no transmission of disease. But it also loses a lot of the benefits of living healthy bone. You lose these cell signaling properties, and you lose, so it sort of works as a scaffolding to kind of hold the shape for your body to then come in and turn that bone graft over. There are synthetic materials that are basically chemically the same composition as bone is. So you can use synthetics, you can use cadaver bone, which is probably what the majority of things are. And then you can use autogenous bone. And anytime we're doing a big graft, I still like to try to get some autogenous bone. So we'll go in and we'll scrape a little bone from the neighboring area just so that we can add that to the cadaver bone. And that gives us some of those benefits of having the native bone there.
So can you go in if an implant is for some reason losing bone? Can you go in and add in some cadaver bone to build that area back up?
Yeah, it's a good question. Unfortunately, this is probably where we have the most room for improvement when it comes to implant dentistry, is treating failing or ailing or failing dental implants. You can try, but one thing about these materials, any biocompatible material is very, very difficult to sterilize once it's in. So this is true for prosthetic joints. This is true for dental implants. What happens is the bacteria that get around that implant, they develop what we call a biofilm, and it's just this really adherent film of bacteria. And so to go in there, we use lasers, we do all kinds of stuff to try to make that work. And we try, and maybe 40% of the time we get some improvement, but it's nowhere near as predictable as we'd like it to be. So a lot of times, once you start to lose bone, we can do things to kind of try to make that area more cleansable. So you can have an implant that's lost a lot of bone around it. If it's in the back of the mouth, nobody sees that. You might just kind of ride it out for another 5-10 years before that implant loses enough bone where it eventually will get loose. If you start to lose bone in the front, obviously it becomes an aesthetic problem quicker, and so that can cause issues. But it's possible, but challenging. And like I said, it's the area where I'd like to see some improvement made quickly, because we're getting a lot more implants being put in, and eventually we're going to have to hopefully come up with better solutions for saving those ailing implants.
Sorry, another question. Long ago, I researched a little bit about it, and they were talking about the full replacement, like you mentioned.
Yeah.
And there were two different types. Some of them were removable, and others were permanent. Which ones are, have taken the mainstream?
It's a good question. There are advantages to both. The problem with something that goes in and stays in is, for some individuals, hygiene can be an issue. On the top jaw, that implant or that bridge has to kind of kiss the gum tissue so that you're not whistling underneath that bridge, but it also has to be cleansable. So if you have somebody that has dexterity issues, or for whatever reason you're having a hard time finding that balance, and if you make something that comes out, you can just clean that really easily. So I think most people, if they have the option, prefer to have something that goes in and stays in, simply because that feels and functions. I think the biggest difference is patients, even if they have something that comes out that's great and works and functions well, they still sort of feel as that's a denture or a prosthesis. Whereas once it goes in and it stays in, they start to kind of talk about it more of like my teeth, it just seems a lot more like teeth, and not necessarily, you don't refer to, if you have a bridge, nobody refers to it as like a prosthesis, it just feels like normal teeth for the most part. And so I think that's there's some psychological advantage to having something that goes in and stays in.
So which do you primarily do? And how much does a full restoration like that
We primarily do the ones that go in and stay in unless we have some reason to, like dexterity or something like that. And then it just depends. They are the way that type of thing was designed is that it was designed so that part of the reason we angle the implants and things like that is you're designing that to use the available bone that's there. And so if you're able to do it all in a day without any grafting, which is the advantage of that technique, a lot of times you don't have to do any grafting. And so it can all be done a lot quicker. Like I said, you can have the teeth loaded the same day. But sometimes there's still, just even though we're angling and we're doing, unique things with the implants, there's insufficient bone. So you have to try to rebuild some bone first. But that can range anywhere from probably $22,000 to $40,000 an arch, upper and lower, per arch, something like that, just depending on what you have to do and where you go. I hear it's a lot cheaper in Mexico. We get a lot of people that come to us that have had it in Mexico, and now they want us to help them out.
So when people get their wisdom teeth removed, do you observe the same bone loss and movement of the teeth near the wisdom teeth?
That's a good question. So we don't typically, and the main reason for that is, like I said, the teeth don't, it's pretty rare that I ever see teeth move backwards or tilt distally. And so it can happen, but it is really pretty rare. And so since those wisdom teeth are the last teeth in the arch, it doesn't, typically happen.
How about the 2 or 3 months that you're waiting for the teeth to heal, and how do you eat if you haven't got teeth on the other side like I don't have on this side?
Yeah, it's if you're replacing a single tooth, most people are excited to get that tooth back, but they function okay while they're missing it. Yeah, it can be a challenge. There can be periods of time where if we're doing big, complicated bone grafts and things like that, it might be that you had a denture that fit okay, but now we've done a bone graft and changed the volume of the arch, and now your denture doesn't even fit. And so sometimes there's just a period of where you're going to be on a softer diet and have to kind of eat those.
Doesn't the soft diet prevent you from chewing, and therefore you talked about chewing and how...
Right, yep. Yeah, so you kind of have to bite the bullet, unfortunately, for a couple months sometimes, depending on the situation. But, you can, and people are, nowadays with the improvements in the surfaces of the implants, people are pushing the envelope as far as how quickly are we putting a tooth on an implant.
Would you have a temporary, at that time, on this side, for example, where it's going to be an implanted crown?
Yeah, the problem if you put a temporary on an implant while it's healing, you increase the risk of that implant not integrating to the bone. So if you have multiple implants and you splint them all together, then you can get some function out of implants immediately. But if you just have a single tooth, then usually we don't do anything to load any forces on that implant for at least 6 or 8 weeks at the earliest.
Right. Yes, sir.
Two quick questions. First one is, you didn't say how long a period of time before it's too late to do an implant. What typically, is it 3-4 years?
Probably the most important factor there is when the tooth was removed, was there bone loss around that socket? If the tooth was taken out and there's bone loss, because the bone's real kind of eggshell thin, and a lot of times it'll kind of break away, and now we've lost that housing, then as it's healing, it has a tendency to just collapse on itself. And we see a lot of bone loss within the first 8 to 10 weeks. And then that, over the course of a lifetime, it's a real slow process, but a gradual, continuing process of bone loss. So it depends on the individual. But if we put a bone graft in at the time of an extraction, usually we get 3 or 4 years out of that before you start to get a lot of resorption. But it depends on the individual.
And then second question, do you know of anything that stimulates bone growth so you wouldn't have to graft it from another part of the body?
No, there are things that can improve bone densities, vitamin D, calcium, things like that. That can help the bone that's there be healthier, but nothing other than surgical intervention you can cut bone and slowly expand it and grow bone back that way. That's called distraction. But again, that's a surgery that so there's nothing that there's no supplement or anything to take to kind of make that bone come back. Because essentially what it is, you can have great bone everywhere else in your body. You can have, get a bone scan, everything looks phenomenal, your bones are healthy, but that alveolar bone says, I don't have any purpose because there's no tooth in here anymore. So.
I had one question.
Yeah.
Thinking of implants or thinking of just the general practice of dentistry, what is the next big movement 5-10 years from now? Big change coming.
I think we may get to a point where we're able to regrow teeth and then implant those. So now instead of putting titanium in, we potentially be reimplanting a tooth. So one thing that we're doing now, I don't do a lot of it, but you guys may have heard of like stem cell for injections for knees, hips, things like that. There's a service out there that when we take out wisdom teeth, that tooth usually is, unless it's fully in the mouth, but usually it's impacted and it has a dental follicle around it, and that has a bunch of stem cells. So there's a company that actually, if the patient wants, we can take that follicle and send in those stem cells, and they could use those stem cells they bank them essentially, and they can use that for, injections into joints or whatever for healing, or potentially as the science continues to develop, maybe you're using those stem cells in the future but basically they say, we'll take your stem cells, we'll hold on to them for you in a little storage unit. And I don't know what I think there's some charge or whatever, but then if you ever need that, otherwise you got to get stem cells somewhere else. So you end up getting like a bone marrow biopsy or something like that. So that's an interesting thing. And I think that's probably what we'll see is more tissue engineering.
So that brings us to the top of the hour, and I would like to ask you to give Dr. Clay Van Leeuwen a big hand.